of Balmiki Basti, Delhi. He is presented to the OPD with the chief complaints of breathlessness since 5 months, palpitations since 2 months, and cough since 3 weeks. The patient was apparently well 5 months back when he started experiencing breathlessness on climbing about 3 flights of stairs. The breathlessness was exertional and mild to start with, which has gradually progressed and increased in intensity over the last 3 months. His breathlessness has significantly limited his daily activities, and he feels comfortable only at rest now. The patient has had nighttime awakenings due to breathlessness, which would relieve slowly on either standing or sitting up straight. For the past 2 weeks, he has difficulty lying down straight, and he feels relieved on sitting in an upright position. He sleeps with 2 pillows supporting his back. There's no seasonal variation of breathlessness. The breathlessness was associated with palpitations since the last 2 months. The palpitations were mild to start with, which has now increased in severity. The palpitations are irregular in rhythm and occur on exertion and are relieved on taking rest. They're also associated with sweating and are sometimes felt at night. The cough started 3 weeks back, which was associated with a pinkish, frothy, non-foul smelling, non-blood stained of approximately 5 to 10 ml in amount sputum. The cough was aggravated on lying down with no diurnal or any seasonal variation. There's no history of chest pain, syncopal attacks, bluish discoloration of lips or oral cavity, or reduced urine output. There's no history of fever. There's no history of hemoptysis or abdominal distension, and there's no history of headache. Coming on to the past history, there's a history of migratory joint pain involving the large joints, knees and wrist at around 14 years of age, for which he had taken medications. There's no history of involuntary distal movements. Associated history of pharyngitis, fever, or skin lesions cannot be recollected by the patient. No history of any skin rash, nodules, and small joint pain or deformity. There's no history of drug abuse or previous cardiac surgery. The patient is not a known case of diabetes and hypertension. There's no history of tuberculosis, and there's no history of asthma and any other thyroid disease. The treatment history, there's a history of monthly injections which were given to the patient after the episodes of migratory joint pain, which was discontinued by the patient himself as he experienced no symptoms after 3 years of the treatment. Coming on to the family history, there's no history of breathlessness or any other cardiac disease in the family. There's no history of cardiac related death in the family. Coming on to the personal history, the patient consumes mixed diet. His calorie intake is around 1600 kilocalories per day, and the protein is around 35 grams per day. He has a disturbed sleep due to episodes of breathlessness, which are released as the patient sits in a semi-erect position. Or because he started sleeping in a semi-erect position, he feels relieved in that position. The bowel and micturition habits are normal. The patient does not smoke, does not consume alcohol, and there's no history of any other drug abuse. The socioeconomic history of the patient belongs to an upper middle class according to the modified Kuppuswamy scale. Now just summing it up, a 30-year-old gentleman presented with NYHA grade 4 dyspnea associated with paroxysmal nocturnal dyspnea and orthopnea, irregular exertional palpitations, and cough with pink frothy non-foul smelling expectoration, and a past history of migratory joint pain. So I'm finished with the history taking.
Okay, good job. Good job, Sparsh. It's quite a florid history and something what you read in textbooks, and you don't actually very often get it in the ward. Something is amiss, something is missing, something is complicating, added on features. not related to the primary cause, but it's quite a good history.
Thank you.
Quite a florid one. Now we need to have a assessment on this. But before we get to the assessment, I would like to invite the comments. Isn't it very unlikely that there is no history of cardiac related death in the family? Somebody is asking. Sparsh?
Yes, sir. Ria
Somebody is
Vasan has
saying,
asked. Yes, sir.
yes, you can read it. So Rhea is asking, isn't it very unlikely that there is no history of cardiac related death in the family?
So, I up till now, if we see the history, I'm probably thinking of a rheumatic etiology. So it is not likely that there should be a cardiac related death in the family. Supposedly, if there were some genetic component associated with it, then we could have linked it to the cardiac related death. That's why we had taken in the history. We had asked the patient if there is any cardiac related deaths or any other problems like breathlessness in the which runs in the family, and he does not give any history of that. So I
Yeah,
think that answers the question.
so you are thinking of a acquired disease, which is
Yes, sir.
rheumatic heart, but maybe Ria is thinking that we have already done a session on rheumatic heart disease. Why do you think this question has cropped up in somebody's mind?
I don't know, sir.
So we would have to come back. You will know it. We would ask
Yes.
you, since there are no more questions, how do you interpret? What is your impression, clinical impression based on this history? Can you put that summary in front of everybody?
Yes, sir. Sure, sir. Is it changing?
No, not yet.
Yes, sir.
Good, good, very nice. So, how do you react to this history?
So, uh, so the patient is presented with three chief complaints, sir. Firstly,
Okay.
he has been having breathlessness for the past 5 months, and then during the course of time, he has had a history of palpitations and cough. So, if he had presented with cough initially, then we would have thought of a respiratory pathology. Because he was presented with breathlessness since 5 months, and adding on to that, he has had palpitations and cough associated with breathlessness. So, my first, you know, I first thought of a serious pathology. I've not quite yet ruled out the respiratory pathology, but I've kept it in at a my lower down in my list. I think cardiovascular system involvement is should be thought of first because breathlessness is the first issue and cough has presented almost around 4.5 months later.
So,
So think
yeah, please carry on.
so after that, sir, I wanted to ask about what could be the probable cause, what could be the etiology behind the cardiovascular system. Uh, Either it is an acquired disease or it has a genetic component. So we had asked about any family history or does he consume an alcohol, but he is quite young to have presented with dilated cardiomyopathy. He would have been a chronic alcohol. He should have been a chronic alcoholic of around. He should be consuming around for around 20 to 30 years, I guess, if he had to present with dilated cardiomyopathy. Uh, so then there was no genetic component. There's no family history. There's no substance abuse history. There's no associated fever. So I wouldn't think of infective endocarditis if I had to see the probable differentials, and then I would go on to the examination to confirm my diagnosis.
Okay. Now, you see, Nilayan, I think, had done that presentation. So there is a couple of questions. We have done this rheumatic heart disease. He says, but lung pathologies, respiratory causes, can they present with breathlessness alone?
So there is usually cough associated with breathlessness in a
Okay.
respiratory pathology.
Yes. Can
That's the
you think of
most common presentation.
can you think of some lung pathologies that do not have cough expectoration with breathlessness?
Pleural effusion, sir.
Yes, that is one. So all these things that occur outside the lung, whether it is pleural effusion or pneumothorax, they can
Yes, sir.
present with acute onset breathlessness. And
Yes,
depending
sir.
on how it is, it would hang on. Anything else?
Interstitial lung disease, sir.
Yes, you have seen the whole of COVID for 1.5 years.
Yes, sir.
Everybody came with breathlessness, and there was not much of cough there. Many of them, or most of them, had interstitial involvement. So, breathlessness is a characteristic of lung disease. So, if you said pleural effusion or pneumothorax, but if it is interstitial lung disease, how does the breathlessness of interstitial lung disease differ from that of cardiac failure?
So interstitial lung disease, breathlessness will not be associated with cough or any expectoration.
Okay, so that is same for the two.
And so if it if we have to differentiate between a cardiac and a respiratory pathology, as you're asking, so there'll be no symptoms of paroxysmal nocturnal dyspnea or orthopnea in that case. In an interstitial lung disease, there won't be a finding of PND and orthopnea, sir. And there'll be no
Okay,
positional
so
variation.
first tell me one thing. Are you accessing all these comments and queries like from Pariniti and Shreya?
No, sir, it's obvious, sir. I've already taken the history.
Okay, no, I just want to know because they are putting very good comments. So you are not the only one. There are many others who have come up and said
Yes, sir, I can
orthopnea
see.
and PND. You can see it. So
Yes,
anyway,
sir.
so I'll have to catch you on something that is not put out there. So one is PND orthopnea. You don't expect an ILD. Is that right?
Yes, sir.
Why? Why do you get them in failure, cardiac failure, and not in interstitial lung disease? What is the typical history of an interstitial lung disease? Why don't they get orthopnea and PND? Or let's say PND.
So, because PND occurs because during night, in deep sleep, there's a sympathetic overdrive, and because the heart is not pumping effectively as it should be in a normal person, therefore it cannot draw the fluid out of the lungs.
So left ventricular end diastolic pressure, when it is elevated, that is the physiological definition for heart failure.
Yes, sir.
And when it goes beyond 25, that is the requirement for PND. Now, interstitial lung disease typically, it's something like a classic example is given when, let's say, you are in a aeroplane, and you're walking down the aisle. If you go from one end to the other end, before that, one will start getting breathlessness, and you take a rest, it settles down. Not only breathlessness, in fact, if you walk down the aisle, one gets breathless and cyanosed also because there is a problem of diffusion. So this is a typical example, and you take it because high up the aircraft would be pressurized to about 7,000, 8,000 feet. So there is already low oxygen, and their diffusion is low, and that is where they suffer so much. But then it's a very typical example in two sense. One is when they walk, they get breathless and cyanosed, and when they take rest, they become all right. Cardiac angina, does become all right when they take rest. But failure takes much longer, if at all it improves. So the failure would actually hang on, and it will not just be you sit for 2 minutes and you are all right. So there is a basic difference between the two, but there may be no cough in ILD, and there can be cough in cardiac failure, as you have elicited in your own patient.
So you mean in a respiratory cause, if there is an interstitial lung disease, so the
Yeah.
patient symptom will resolve over time. But in a
No,
cardiac,
no, they don't.
oh no,
There is no time in the sense if they are precipitated with exertion,
yes sir,
then you settle down. That increased requirement goes away, and they come down to
yes,
the baseline, which also means an advanced ILD would also have orthopnea.
yes sir,
So it would not be appropriate to say ILD does not have orthopnea. Orthopnea would come in, set in ILD, because ILD as such, if it is idiopathic, it does not have a very good lifespan. So the prognosis is not so good. So over the next couple of years, it would go down, 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 and they would have orthopnea. So orthopnea can be there, and that orthopnea, if it just hangs on, you could say, it is coming into PND also, and it's not the ventricular and diastolic pressure going up beyond 25 that is precipitating PND, but it is the hypoxia that is precipitating it. So apart from these two things, which you said cardiac and we touched upon one pulmonary, is there anything else which can present with the breathlessness in a
yes
young
sir.
man?
So if is highly anemic, so there's or
Yes.
if he has a thyroid problem, thyroid toxicosis, then he can have such symptoms. Thyroid will
No.
not as present with breathlessness, rather it can present with palpitations. But an anemic person might present with a breathlessness.
Good. Now you have corrected it. Actually, you were right. Thyrotoxic patient can present, thyroid disease patient can present with breathlessness also. But thyrotoxic patient very often will present with palpitation. If they get breathlessness, it would be from a thyrocardiac disease. So you can have a cardiac involvement in thyrotoxicosis. You can also have cardiac involvement in hypothyroidism. So those are different things, but that we are talking in terms of the reason for breathlessness in a thyrotoxic or a hypothyroid disease would be cardiac reason.
Yes, sir.
Palpitation would be independent, but breathlessness would be cardiac. So they would be classified under breathlessness from cardiac pathologies. And cardiac pathology is secondary to thyroid disorder. So, but the anemia part is very well taken, and this is the triad that you should always keep in mind whenever you are in the ward or you are outside. What is the triad? The hemoglobin that carries the oxygen, the heart that pushes out those RBCs into circulation, and the lung and blood circulation interaction in the lungs where the exchange occurs. The breathlessness would occur if any or more than one of these components is affected, right?
Yes.
In fact, it is very interesting if you would look at it. In a patient with anemia, let's say the hemoglobin has come down from 14 to 7. At 7 grams, the saturation would be normal, oxygen saturation. You do these pulse oximetries, you have done lots of them in COVID. So that would be normal, but they still would be hypoxic. So hypoxia would be a combination of cardiac, hemoglobin, and the respiratory things put together. That also brings us to another alternative, and that is where there is a ischemic heart disease, let's say in the elderly. Now, those persons' cardiac myocardium is compromised because there is ischemia of the myocardium also. If they develop anemia from, let's say, 14 to 7 grams, their angina will be precipitated. You correct their anemia, their angina will get corrected. So this also has an implication on the management of these patients. So I think one thinks of all these things in that context, but tell me any other cause for breathlessness apart from these three major domains. Nandini is suggesting that could it be anxiety that can cause breathlessness? Okay, so there is a very nice, the line is up and up. And so, anxiety, you don't actually have breathlessness because there is no hypoxia, but you have a rapid and fast breathing, all autonomic sympathomyotic activity. So the breathing rate goes up, the depth goes up. This kind of a thing can be confused with breathlessness. And when you are posted to emergency, medical emergency, you will see several times these persons, young persons especially, they would come as if they are huffing and puffing. It's 17 hours. And when you do their ABG or whatever you want to do, you will find they're fine. ECG is fine, chest X-ray is fine, everything is. And they're good otherwise. They have no other medical history of a disease previously. Now, these are the persons you will see, especially, the one area that you see is conversion reaction in hysteria. So they come like that. Anxiety, as she said, is another one. But there can be areas when they don't have this and they're still having deep breathing. And you would have seen them in renal failure, chronic renal acidosis, they call it. Diabetes, you would have seen it. So whenever there is what is called metabolic acidosis, there is a compensatory need to call it tachypnea. So tachypnea can be mistaken for breathlessness. In fact, you can't blame anybody because they tend to present the same way. The idea is when you're keeping in mind cardiac, respiratory, and hemoglobin hematological, you should not forget the metabolic causes. And in metabolic causes, one of the differential would also be anxiety or the conversion reaction. So whether it is central cause, osmosis breathing, morbid obesity, ketoacidosis, lactic acidosis, they can all cause it. So many of them would come in, right? Now, you are picking out of these five, you are picking on the cardiac. We come back to Ria's question. Is it possible? Yeah?
Yes, sir.
So we come back to the question, is it possible that it is cardiac disease all right, but it is not rheumatic? Because for calling it rheumatic, you have to fulfill the modified
Yes, sir.
Jones test. You don't have. So what other cardiac disease, you said there is nothing else, you were trying to rule out ischemic and all. What other cardiac disease, apart from valvular heart disease, can come into a
Car
30-year man?
cardiomyopathy, sir.
Cardiomyopathies, yes, they can be, Ragini says DCMP, so it can be a DCMP primarily, it could be secondary to thyroid or any other disease, or it could be very often secondary to a viral myocarditis. So cardiomyopathy is another one. Anything else? Can it be atrial fibrillation in a young man? Usually, atrial fibrillation in a healthy heart does not precipitate failure. Ventricular arrhythmias do, atrial does not, but it can sometimes occur. Anything else? So there are two things here. Normally, we have associated ischemic heart disease with the elderly, 60-year-old, 80-year-old, and 50-year-old. They would have it, or they have comorbid conditions. But for the past few decades, especially in India, we are seeing that the ischemic heart disease, myocardial infarction comes in the young also. We get these patients who are around 20 years and they still would have it. 30 years is nothing unusual. And also, there could be something that occurs in a young man and has got a family history.
Young man.
And a family history for cardiac disease. What kind of a cardiac disease? Where they can present with breathlessness, maybe some valvular, some septal hypertrophy, asymmetric.
Hypertrophic
Also,
cardiomyopathy.
yes, so many have written here. I can't even read the names. I'm so impressed. Very good, very good. Now, is it so? That has a family history. So we come back to the same question. Based on this history, family history of cardiac disease or sudden death would also be important. What about the dyslipidemias or hyperlipidemias? Familial dyslipidemia.
Hypercholesteremia.
Can they come into this?
So they are a risk factor for ischemic heart disease, sir.
They are a risk factor for ischemic heart disease. So we'll have to actually think of ischemic heart disease. Most of the ischemic heart disease is genetic, familially determined. Some of them we can unravel with things like hyperlipidemia, but their role as such is small in the causation, but they need to be treated separately, and so that needs to be looked into. But no family history here. Okay, that is okay. We are not saying that it is Hokam. Now, one more thing that I want to ask you is, Sparsh,
Yes, sir.
you said there is no history of hemoptysis,
Yes, sir.
and you said there is pink frothy sputum.
Yes, sir.
So how do we reconcile? Are they similar, same, mutually exclusive?
So he has
The
expectoration
comments
of
of the
around.
other.
So his
Yes.
expectoration is around 5 to 10 ml per day. That accounts to around 1 to 2 teaspoonful of expectoration, and it
Okay.
has a slight pinkish tinge, or we can say it is
Okay.
pinkish in color, but we cannot
Right.
term it as hemoptysis.
I'm asking you. I would ask others also. I would ask others also to comment on this. What is the definition of hemoptysis? Definition of hemoptysis is coughing out of blood.
Yes, sir.
Whether it is clot, whether it is old, whether it is fresh, whether it is pink, whether it is frothy, any blood that comes out will qualify into this. So there would be overlap in that area. And just keep that in mind. Froth needs alveoli. Okay, that is okay. Blood in the sputum, that is fine, is hemoptysis. Many Pariniti has written, Ragini has written. And now let's ask you something. There is a query that has come. Why is it not corpulmonal? Let's say TB can cause it. Many other pulmonary conditions can cause it. Pulmonary arterial hypertension can cause it.
So it so for saying it to be a core permanale, if I taken the exam based on the history, I'm not very clear how to say it, but if I take an examination and I'd found some pathology in the left side of the heart, then I would not go towards core permanale, because for core permanale, a respiratory pathology should cause the right ventricular dilation, or if there is a what do we say? Uh,
Yes, yes, you're right. So the I would take it in a different way. So whenever you're working on a case and we say, we are working this case of cardiac failure or congestive cardiac failure or congestive heart failure. That actually is a kind of a dustbin for me. So you should think the same way, and you should try to figure out whether it is left ventricular failure or it is right ventricular failure. If it is left ventricular failure, that is what we commonly mean when we say cardiac failure or congestive heart failure. But one can have a dominant, predominant, isolated, or starting off as right heart failure. Right heart failure means right ventricular failure. We're not talking about atrial, so ventricular failure. So RVF, if it occurs primarily, then the conditions that you'll see are slightly different. And LVF would be different. So that you should keep in mind more than whether it is TB or CCP. They are more into differential diagnosis that you can bring it in.
So in this history, there were no symptoms of headaches or decreased renal, urine output. So we cannot say that whether it is a left heart failure or right heart failure. To say right heart failure or a left heart failure, we need to have examination findings. Is it not, sir?
No, not necessarily. Not. Can you think of some right heart failure conditions that you have seen in your wards?
So core pulmonary can lead to.
That is one. Any other? I'm not touching upon that because that may have a primary, pulmonary symptoms. Any other, by the way?
So a thrombus, an emboli blocking the pulmonary circulation can lead to pulmonary hypertension.
You look at it this way. When you have a left ventricular failure, that leads to congestion in the lungs, which give rise to all these signs and symptoms of LVF. When you have a right ventricular failure, that would be right ventricular end diastolic pressure is elevated, physiological definition. That would reflect into JVP first.
JVP.
LVF will not reflect into that.
Yes.
That you will not find on history. But if it is JVP in the superior vena cava, in inferior vena cava, it is liver, which will get congested and pulsatile.
Tender hepatomegaly.
Pulsatile, but they'll tell you about hepatomegaly. There is discomfort in the right hypochondrium. And down below, it will produce edema first.
Yes.
Yeah. So it's a different matter that the commonest cause of right ventricular failure is
COPD.
LVF.
Okay, sir.
So when you have a case like this, what you are presenting, then this LVF would eventually complicate also into right ventricular failure. Which one came first will help you in making the diagnosis.
Yes, sir.
So both will be there. And one more thing, when you discuss a case like this, and you bring in things like TB and CCP and others, you don't have to say because this thing is not there, so this diagnosis is not likely. The more number of differential diagnoses you have on your platter, not only will it help you in the exam, where the examiner will be very happy that you're thinking of everything, but it will actually also help you in your real life when you will find that majority of the cases anybody can diagnose, but there's few difficult cases or those that don't get diagnosed, you will pick up because you thought of far-fetched differential diagnosis. So if you have these things, then you should bring in more differential. And one more thing, generally in clinical medicine, absence of one of the features. So let's say a right ventricular failure has got dozen features. Absence of one feature does not go against its diagnosis. So don't look at the negatives. Look for the positives. This person has got pedal edema. Can it be CCP or constrictive pericarditis or whatever? No, there is no pedal edema, there is only breathlessness first, and this edema came in months later. Maybe it is cardiomyopathy. So that will also help you. And Ria has come out with the thing that MI can cause right ventricular failure. Yes, of course, Ria, but that is uncommon, and that's a special MI. Hepatomegaly, edema, fetal edema, LVF. Okay, now I want to ask you one more thing. The first line reads, a 30-year-old gentleman presented with NYHA grade 4 dyspnea. What is NYHA grade 4 dyspnea?
So NYHA grade 4 is when a patient, so there's a mistake, there should be grade 3 because the patient feels comfortable at rest. I
Okay.
did not, it should be grade 3. But there was some confusion that orthopnea comes under grade 4. But the
Yes.
patient says that he feels relieved uh, at resting, that if he does not work, he does not have much problem. So where should have I put uh, this
Yes.
patient under? I had no idea. So if because he presented with orthopnea, I went towards grade 4.
Okay. Okay. We'll hear the comments, but while they're putting out their comments, tell me something. Wasn't it that we do the same class for 2 half batches? I see some. This batch didn't attend the first one, is it?
No, so
Or
they're
some of.
different batches, batch A and batch B. So we are batch
Okay.
B students.
Fine. Right. But I think some of the things are common because when we discuss the RST, probably or something with you or somebody else. Anyway, so this NYHA number one, NYHA is not grading. Okay. There is no grading of dyspnea in NYHA.
Okay, sir.
Yes. New York Heart Association puts them into classes. Class 1, class 2, class 3, class 4, because it looks at not only the breathlessness, it looks at the other aspects also. So anyone who is orthopnic would go into the most severe category, that is NYHA class 4 symptomatic. The grading of dyspnea is sometimes undertaken in pulmonary disorders, but in cardiac disorders, NYHA goes with a wider domain where you can look at the symptoms also. So you must take care when you are presenting it like a cardiac case and you have done the classification, then you take care of all the symptoms also. Haven't we spent a little more time on your history, Sparsh? Should we go to examination?
Sure, sir. Shubhangi, Sulakshna, Sulakshna.
Good evening. Yes. Good evening, sir. This is Sulakshana Agarwal. I'll be presenting the examination.
Okay.
Sir, actually, I have a doubt in history also. So, can I ask you, sir,
Yes.
yes, sir, you told about some causes of breathlessness. I was thinking of some diaphragmatic disorder can cause breathlessness, like Duchenne's muscular dystrophy or some myopathies type. Can it be the cause of breathlessness, which we should rule out?
Of course. Of course. You see, it's like this. You have these muscular disorders. Not only the Duchenne hypertrophy, you can have the adults also. Myasthenia also you can have. You can have these Landry-Guillain-Barré syndrome also. You can have some of these drugs, aminoglycosides, which affect the NMJ and in sick conditions, ICU and high dependency areas, their lungs, chest wall don't expand much. So when you have these muscle disorders, they usually act through the lung. Lungs are normal, but they can't expand. The features would be like that of lung, whether it's type 1 respiratory failure or whatever, and but the cause would be a the muscular disorder. So it's like what Sparsh was saying. You think of a thyrotoxic disease, but thyrotoxic is occurring through thyrocardic disease, whereas palpitation is separate. So in these disorders, the muscle disorders actually would cause this breathlessness or weakness because the lung function is suffering. So you are right, it would be there, but whether you club it with the muscular disorders leading or working out through the lungs and not through the heart, which can be separately involved, is a different matter.
Yes, sir. Thank you. Um, on general physical examination, the patient was examined with due consent in a well-lit room and was well oriented to time, place, and person. Attitude: patient is sitting on the bed. Patient is averagely built, 75 kgs weight and height 171 centimeters. BMI 25.6 kg per meter square. Next slide. Patient was afebrile to touch. His pulse was 106 per minute, irregular in rhythm, normal force, adequate volume, no vessel wall thickening, and taken in right radial artery in sitting position. Blood pressure 115 up systolic, 86 upon 86 diastolic, mmHg in right arm in sitting position. Respiratory rate 18 per minute, abdominothoracic, jugular venous pressure 7 centimeters elevated above the sternal angle. He had mild pallor, no icterus, no cyanosis, no clubbing, no generalized lymphedema, bilateral pitting pedal edema was present. No signs or markers of infective endocarditis such as PTK, Janeway lesions, oscillatory nodes. No signs of atherosclerosis, xanthomas, xanthelismas. The size and shape on inspection, the size and shape of the chest is normal. Trachea appeared in midline. Presence of precordial bulge was present. Apex beat was seen in left sixth intercostal space, lateral to the midclavicular line. No other visible pulsations were seen. No dilated veins, scars, and sinuses. On palpation, findings of inspections are confirmed. Trachea is midline. Apex beat is hyperdynamic, felt on left sixth intercostal space on the midclavicular line. Parasternal heave of grade 3 on left side is felt. Palpable systolic thrill is present. Palpable P2 is present. Epigastric pulsation hitting the tip of the index finger is noted. On auscultation, soft S1 was heard and P2 was loud. S3 was also heard. A pansystolic murmur of grade 4 with soft S1 and loud S2, best heard in mitral area in left lateral position with breath held in expiration, radiating to left axilla and back with no variation in respiration, is heard using the diaphragm of the stethoscope. The murmur also increases on recumbent position and decreases on standing. Other systemic examination, respiratory system, fine inspiratory crackles heard limited to the base of the lung on auscultation. CNS, no focal neurological deficits were found and mild tender hepatomegaly was present. My summary. A 30-year-old gentleman presented with NYHA grade 4 dyspnea associated with orthopnea and paroxysmal nocturnal dyspnea, irregular palpitations on exertion, cough with pink frothy expectoration, and a past history of migratory joint pain, which is suggestive of rheumatic fever. On examination, elevated jugular venous pressure, pitting pedal edema, hyperdynamic apex beat shifted down and out, epigastric pulsations, palpable systolic thrill is noted, soft S1 and loud P2 heard on auscultation, a pansystolic murmur of grade 4 predominantly heard in apex 4 in apex with radiation to back and parasternal heaving is noted. Sir, I am done with examination.
Yes, I can see that. I'm waiting for somebody who is wanting to ask you any queries or clarifications. And I can see that both of you are resting your diagnosis in a big way on the past history of migratory joint pain. So while they are coming up with their own questions, can you clarify what is this past history that Sparsh was talking about of the migratory joint pains? Can you elaborate, or he can elaborate?
Yes, sir. Sir, actually, migratory joint pain is one of the major criteria for.
No.
Yes, sir.
What did this patient have? I want to elaborate on the past history of this patient. Like when did he get it? How old was he? Or he does not remember which joints? How long?
Yes, sir. Sir, when the patient was around at around 14 years of age, then the patient reported migratory joint pain, which involved large joints such as knees and wrists, and the pain was once felt in was felt in different large joints. At other time, it appeared as that the pain is migrating to different joints.
So you mean one attack of arthralgia, that is what
Yes,
it
sir.
looks like, affecting knees and wrists is sufficient to think of rheumatic heart disease or rheumatic fever at age of 14 that you
Sir, for diagnosing rheumatic fever, there is Jones criteria.
Yes.
Yes, sir. Sir, according to Jones criteria, two major and or one minor symptom plus two major symptoms should be either one major or two minor should be present, or two major symptoms should be present for confirming the rheumatic fever, acute rheumatic fever. For confirming rheumatic heart disease, yes, sir.
No. This is coupled with evidence of streptococcal infection.
Yes, sir. So that is one of the
essential. So don't forget that. Tell me, can anything other than streptococcal infection also cause these kind of pains?
Sir, migratory joint pains.
Yeah, migratory or otherwise. No, migratory is like, it's okay, it's coming. And do you have this reactive arthritis that can come after infections, that can come after eating something, any antigen that you can see? After all, the chronic joint pains or the joint pain that goes for several days or weeks will be less because they've taken some medication, will come back again. Can it be chikungunya? We had so much of joint pains a couple of years back in chikungunya or dengue. Or so
yes, sir.
by itself, it may not be sufficient to think that this history is enough, right? But you would say, because I've also found the disease based on other rest of the examination that concurs with the valvular heart disease, and in valvular heart disease, I have this disease, this history, I would call it acquired rather than congenital, and the age also will support you. So you can say it like that, and then that will help you. The viral arthralgias occur, not only dengue, chikungunya, so many others. Pariniti wants to know, could it be a connective tissue disease that came first attack and maybe the second attack will never come or will come some other time? So there are these connective tissue disorders, reactive arthritis, and there are many of the connective tissue disorders and viral infections that can cause it. Okay, so there are no questions. Come back to your last slide that you were presenting. Okay, no. On examination, yes. So you think this is based on this, your impression is it's a case of rheumatic heart disease. Can you repeat that? Your clinical diagnosis have you written in the next slide?
Sir, yes, sir.
Yeah. Please bring it out.
30-year-old male with chronic onset NYHA grade 4 dyspnea, having acquired valvular heart disease of probable rheumatic etiology, severe mitral regurgitation with pulmonary hypertension and atrial fibrillation with evidence of congestive heart failure and no evidence of infective endocarditis.
Good, 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 good. Now, let's take them one by one. Severe
Yes, sir.
mitral regurgitation. Why do you say severe mitral regurgitation in this case?
Sir, severity of any valvular disease can be
No, why
can be
mitral
tested.
regurgitation? Sorry, why mitral regurgitation?
Sir, because of the murmur which was heard, pansystolic murmur heard at the apex of
So what are the
apex.
causes for pansystolic murmur?
Mitral valve prolapse. In the apex, mitral valve prolapse and mitral regurgitation both can cause pansystolic murmur at
No,
the
tell me
apex.
all causes, because you know apex and elsewhere it can get distorted when there is a cardiac enlargement. So the right heart can come on this side, and depending on which of the ventricular will hypertrophy or dilate. So tell me all causes for pansystolic murmur that you find on cardiac auscultation.
Yes,
Septal
sir.
defects.
Sir, other causes can be aortic stenosis or hypertrophic cardiomyopathy. Yes, sir.
Remember
Or
only
ventricular.
three causes.
Septal
Okay,
defects. Ventricular septal defect.
one septal defect,
Ventricular septal defect. Yes.
mitral regurgitation, and third one is tricuspid regurgitation.
Yes, sir.
Okay,
Tricuspid regurgitation.
so when you get pansystolic murmur, and pansystolic murmur by definition is one which starts with S1. If you hear
Yes,
it
sir.
anywhere, you will think of VSD, MR, TR. Okay,
Yes,
so
sir.
why is it not TR? You said there is a pulsatile liver and there is JVP which is elevated, which will be there because of MR also. Why is it not TR? Sorry.
Sir, it cannot be, sir, we ruled out TR based on the location of the murmur which was heard, plus S3 was also heard, which is late diastolic sound, third heart sound. So S3 is strongly suggestive of enlarged left ventricle or volume overload. So based on it, mitral regurgitation is more likely because tricuspid regurgitation, the murmur for the tricuspid regurgitation is not heard in the apex, but heard in the second intercostal space on the left side of the sternum.
So this is not right. You see, as I was telling you, when
Yes,
you
sir.
have MR or TR, in MR, the chamber that will dilate would be left ventricle.
Yes, sir.
In
Yes.
TR will be the right one. So the anatomy, what you call the parasternal, the apex or the base, and those things don't become very relevant. They can be distorted. They are okay in a so-called healthy person. As
Yes,
for
sir.
the S3, when you say S3, like when you say congestive heart failure, then one thing that we are speaking of left ventricular failure, which we, as I said, is the commonest cause for the RBL. Similarly, S3, when you say S3, we mean S3 can be left-sided also and right-sided also. So when you say S3, we mean left-sided, but it does not mean that you cannot have a right-sided S3. So you can get right-sided S3 also. So you'll have to give us some more reasons as to why it is not TR. Anybody?
Sir, sir, one more thing that we can rule out TR. In mitral regurgitation, we predominantly will find pulmonary findings such as pulmonary hypertension and alveolar edema. But in tricuspid regurgitation, we may find JVP is raised, but here JVP is normal. So that's why it can also be the cause.
Okay.
So may I, Bhajan?
Yeah, please.
So
Sorry. Yeah.
most commonly, mitral valve is involved because the pressure of the left heart is more. So uh, mitral valve is more involved, but we can have a tricuspid regurgitation, but the findings would have been different. If there would have been a tricuspid regurgitation, the right heart would have, the right ventricle would have dilated. So we would have found a parasternal heave, maybe, and there'd be shifting of an apex beat downwards, downwards and outwards due to the RVH, right ventricular hypertrophy. Uh, and there'll be symptoms of, I think there'll be more symptoms of there'll be pedal edema, abdominal distension, and pulsatile hepatomegaly. They'll be
So,
prominent.
but she said there is parasternal heave grade 3.
Yes, sir. Sir, we can rule out. Sir, can we rule it out based on jugular venous pressure? Because in tricuspid regurgitation, yes, sir.
Let's go one by one.
Yes, sir.
So one is, it is the left ventricular enlargement which displaces the apex down and out.
Yes, sir.
The right
Okay, sir.
ventricular will be out and out. JVP, you're very right. Actually, JVP is the give way. So when you look at the JVP in the case of TR, is a V wave which comes like this. And the same thing
Yes,
causes the
sir.
pulsatile liver. And the pulsatile liver will be very big because the onslaught of that back pressure is borne by the liver before it goes to the edema also. So there are many areas, and then of course a change in the intensity of the murmur with inspiration and expiration, and some other maneuvers that you can do. Now, as for the common, which one is common? The MR is more common, and MR is very varied. Remember, MR, when you say, would not mean that it is rheumatic. There are dozens of other causes. For MS, that is not so. MS, there are just a couple of causes. So MR is usually organic from one of the many causes out of the dozen list, a couple of dozens that are in the list. TR, organic TR is uncommon and infrequent. TR, if you see, tends to occur secondary to pulmonary arterial hypertension. And you said P2 is loud, and you have put in your diagnosis also pulmonary arterial hypertension. That will cause the TR. Now that brings us to another query that comes from Shreya. Is it pulmonary hypertension or pulmonary edema that is responsible for the breathlessness?
Sir, I guess it is pulmonary edema because pulmonary hypertension causes pulmonary edema. So,
No, both can cause it
and
because you primary pulmonary hypertension also, which presents with breathlessness. So both can independently cause it, but in the case of valvular heart disease of rheumatic origin, what will happen is the pulmonary hypertension would be secondary to the failure, as you said. Okay, so the
yes, sir.
next, so let's come back to your diagnosis, please. We were discussing your diagnosis.
Yes, sir.
Yeah. So that is mitral regurgitation. Okay. So you say because it is down and out. Look at the apex beat. When it is down and out, we are speaking in terms of left ventricular enlargement or hypertrophy. It can be,
Yes,
say
sir.
the beat moves down and out, it is left ventricular enlargement or left ventricular hypertrophy. How do you differentiate left ventricular enlargement from left ventricular hypertrophy on clinical examination?
Sir, based on auscultation, we can differentiate both of them because in left ventricular hypertrophy, we may find a fourth heart sound that is S4, which is early diastolic, but in left ventricular enlargement, we will find more likely S3, which is late diastolic heart sound, third heart sound.
No, something more.
So in ECG,
And
Q waves are more seen if the left ventricle is dilated.
Clinical examination.
Sir,
Very good. The word is not hypercontractile, Nilayan. So when you look at the apex beat and you look at the character of the apex beat, and Sulakshana, you said it is hyperdynamic.
yes, sir.
So the apex can be normal or tapping or hyperdynamic, or the last variety is character of the apex beat is heaving.
Sir. Yes, sir.
Remember
Heaving.
heaving? So remember two, hyperdynamic versus heaving. Okay. So if you put the finger here on the apex beat, in hyperdynamic it is like this. In heaving it is sustained for long time, more than a third, and then it comes back. So it is like this is heaving. It is pushing it, trying to push it, but finds it difficult, so it takes more time to reach the apex. Whereas hyperdynamic is like this. So when you have a hyperdynamic apex beat, that indicates an enlargement because it is from the volume overload. So hyperdynamic apex beat means a volume overload, like what occurs in mitral regurgitation. So the blood goes into left atrium, comes back, and then left ventricle has to push the old blood and the new blood. It goes and more comes back. So the volume enlarges the left ventricle, and that would be seen as hyperdynamic. Whereas, take the case of aortic stenosis, which you were mentioning a little earlier. The left ventricle is trying to push, but it cannot push because there is a stricture. So it tries to push like this. It takes more time and then comes back. It tries to push like this. That is called heaving. And what does it lead to? When it has to push more and more, it causes hypertrophy of the ventricular wall muscles. And that is left ventricular hypertrophy. So hyperdynamic would indicate all those conditions which cause volume overload. Whereas heaving would be something which causes pressure overload. The direct obstruction is one cause. So I think the very fact that it is hyperdynamic would favor the and down and out apex beat with hyperdynamic would indicate that there is a left ventricular enlargement, which you can say is from mitral regurgitation here, or somebody was suggesting you dilated cardiomyopathy or whatever. Now then you come to pulmonary hypertension. Why do you say pulmonary hypertension?
Sir, uh, because on pulmonary clinical examination of the respiratory system, it was suggestive of alveolar fluids. So, since due to mitral regurgitation, it can cause pulmonary hypertension. So, it can be noted that the pleural fluids can be secondary to pulmonary hypertension. That's
So
why.
this is your assumption that there is a left ventricular failure and there is pulmonary edema and there is fluid. So it might be leading to pulmonary arterial hypertension. But we need to see some definitive positive
Sir,
finding.
sir, pulmonary capillary wedge pressure, which is on investigation, which we have calculated.
Clinically, signs on your clinical examination. You said it also. You said it actually twice.
Sir, loud P2.
Sir, palpable P2. Sir, palpable P2. Yes, sir.
Okay, palpable
Loud.
P2, loud P2. Though both the things you said. Now, why the loud P2 is indicative of secondary pulmonary arterial hypertension? Okay. P2 is a component of second heart sound.
Yes, sir.
So how do you know whether the sound that you were hearing as loud was A or P? It could be loud P2 or it could be loud A2.
Sir,
Difficult question.
splitting of the
You never
sir,
talked about
splitting of
splitting. You're right. You never spoke
yes,
of the
sir.
split. So remember, whenever you comment on P2, it would be binding that you have defined the splitting upfront. I will not insist from any one of you at this time, particularly when last 1 year has been COVID and you have not probably seen many cases. But in your life, for your life, when you are practicing, remember it is always a good idea to comment on the splitting first and then comment on any P2 or A2, and then you'll be able to find out where it is. Why do you say there is atrial fibrillation?
Sir, irregular heart rate is
There's
suggestive of atrial.
there are so many causes. A heart rate of 106 per minute irregular, that is what you said. And you are thinking of
Yes,
atrial
sir.
fibrillation. Why atrial fibrillation? It can be
Um,
ectopic, it can be Benjamini, it can be so many things.
Sir, mitral regurgitation is strongly associated with atrial fibrillation.
No, that is very nice. That is very nice thinking. That is very nice thinking. But
So we
then,
would do pulse deficit.
it's like what you were saying, I would expect the pulmonary hypertension to be there because this person has probably got chronic left LVF. So that is okay. But whenever you have irregular pulse, there are two things you must look for: whether it is regularly irregular or it is irregularly irregular.
Yes, sir.
Regularly irregular pulse will not be atrial fibrillation. Like I was saying, you're going to have bigemini, for example. Irregularly irregular is the hallmark of atrial fibrillation. Okay?
Yes, sir.
And what is the second thing that you need to have? You can count the, what do you call it? Pulse deficit. So you count it at
Yes,
the
sir.
apex, you count it at the pulse and see how much is the deficit. Yeah? And Swati will tell you if the deficit is more than 10 per minute, then you think of atrial fibrillation as one of the possibilities. And third thing, which
Okay.
is very important, is atrial fibrillation is a fast ventricular rate. Fast ventricular rate. So if you get a irregular pulse of 90 or 96 or 100, it is not likely to be unless they are on treatment. So without treatment, it will not be like this. So atrial fibrillation with evidence of congestive heart failure, or you could have said it left ventricular failure, biventricular failure, whichever one, and no evidence of infective endocarditis, even though you didn't tell us whether you had looked for the splenomegaly, whether you had looked for the clubbing. Did you look for clubbing?
Yes, sir. There was no clubbing.
Clubbing. And you didn't look for into the eyes, and there are no clinical symptoms anyway. So that is where you stand with your case of suspected rheumatic heart disease, severe mitral regurgitation, secondary pulmonary arterial hypertension, atrial fibrillation, and evidence of congestive cardiac failure. Okay. So I don't think we
Sir,
have time. Yeah, please.
sir, infective endocarditis was ruled out based on Janeway lesions and osseous nodes.
I heard that.
Nose,
But they
yes,
are not commonly seen. So that is why I did not comment on that. The most common
yes, sir.
thing that you see is splenomegaly. Because infective
Yes, sir.
endocarditis, which is bacterial, and an endocarditis that occurs on a deformed wall will be called subacute bacterial endocarditis. A
Okay.
non-deformed, healthy, natural wild valve will be acute infective endocarditis. So when you have infective endocarditis, it is an emergency, it's a medical emergency. If you don't treat, the septicemia will kill that patient. So that causes splenomegaly, all right. but infective endocarditis also causes clubbing. In fact, all the other causes of clubbing would take months and maybe years before they show up. This clubbing in infective endocarditis comes up within days and weeks. Days.
Okay.
And this is probably the only one or one of the few that reverses once you've treated. So these are more important, like splenomegaly or clubbing or microscopic hematuria. You can come out with genuine lesions, and ocular nodes we do see sometimes, and you can see the fundus also for these. But but absence of fever rules out infective endocarditis. Is that a right statement or it is not an appropriate statement?
So it can rule out infective endocarditis because if there is any superlative infection on the valve, then it may cause fever, but the patient is afebrile.
So the same thing which I was telling you, presence of fever goes to support your consideration of infective endocarditis. But absence
Yes.
does not mean that it cannot be there. There are many reasons. Sometimes they don't even feel that there is fever. You have never checked it. You never told us. They never checked it and they didn't bother. And we don't know what they were taking. And it's not necessary. So you can have these features. So, but there are, if it is not fever, it should be something else. So the patient was doing well, and suddenly there is a decompensation. So you say, maybe there is infective endocarditis. Or there is embolization, you say, can it be infective endocarditis? We do the echoes for the vegetations in so many cases where there is no infective endocarditis, but you can still find it. So I know that the presence of fever is there, but what are the Duke's criteria? Okay, you can read that. Let's go to the investigations.
Yes.
Somebody will be writing it there. Yeah.
Sir, I am dealing with the investigations.
Yes.
Sir,
Oh, yeah. Sure. Okay, yeah. Please go ahead.
yes, sir. Shubhangi plus first slide. Lab studies, complete blood count was done to rule out anemia and infection as potential cause of heart failure. Then urine analysis was done because it may reveal proteinuria, which is associated with cardiovascular disease. Serum electrolyte levels were done because
Sorry to interrupt you, Sulakshana. You can also add
Yes,
microscopic hematuria, I was saying. Yeah.
yes, sir.
You can also add the microscopic hematuria for endocarditis.
Okay, sir.
Yeah. Serum electrolytes, yes.
Serum electrolyte levels. It may be abnormal owing to causes such as fluid retention or renal dysfunction.
Yes.
Fasting lipid panel to evaluate dyslipidemia. Blood urea nitrogen and creatinine may indicate decreased renal flow. Cardiac enzymes, troponin 1, CKMB, myoglobin, ABG levels for evaluation of hypoxemia, hypercapnia, and acidosis. Next slide. Liver function tests. Abnormal LFT may indicate hepatic congestion and volume overload. Thyroid function tests. Hyperthyroidism can cause atrial fibrillation and hypothyroidism can cause heart failure. Next slide. Imaging studies, chest radiography, cardiomegaly with cardiothoracic ratio greater than 50%. Early CHF may manifest as capillization of pulmonary vessels, generally reflecting a pulmonary capillary wedge pressure of 12 to 18 mm of Hg. Interstitial fluid accumulates. More advanced congestive heart failure may demonstrate curly B lines. Pulmonary capillary wedge pressure is 18 to 25 mmHg in this. Pulmonary edema is observed as perihilar infiltrates, often in the classic bat wing pattern, reflecting a pulmonary capillary wedge pressure of more than 25 mmHg. Stage 1 congestive heart failure redistribution, blue arrow showing capitalization and red arrow showing vascular pedicle. Next slide. Stage 2 congestive heart failure, Curly's A lines extend radially from hilum to upper lobes, representing thickening of interlobar septa that contain lymphatic connections. Next slide. Curly's B lines, short horizontal lines situated perpendicular to the pleural surface at the lung base. They represent edema of the interlobar septa. Peribronchial cuffing, thickening of the bronchial walls. Perihilar haze, loss of definition of these walls. Thickening of the fissure, fluid in the major or minor fissure beyond the pencil point thickness can normally stain. Stage 3 congestive heart failure, alveolar edema. Alveolar edema with perihilar consolidation and air bronchograms, bad being pulmonary opacities. Pleural fluid, prominent azygous vein and increased width of vascular pedicle. Enlarged cardiac salute. Next slide. A routine 12-lead ECG is done. The major ECG findings. A routine 12-lead ECG is done. The major importance is to assess cardiac rhythm and determine the presence of left ventricular hypertrophy or a prior MI in presence or absence of Q waves. Also used to determine QRS width. ECG changes of atrial fibrillation, absent P waves are seen. Next slide. In atrial fibrillation, absent P waves and no regular distances between two QRS complexes indicate atrial fibrillation. Next slide. Echocardiographic criteria for rheumatic heart disease. Pathological MR and at least two morphological features of rheumatic heart disease of the mitral valve should be present. Pathological AR and at least two morphological features of rheumatic heart disease of the atrial valve should be present. And borderline disease, either at least two morphological features of MR and AR or pathological MR and pathological AR. Next slide. In Doppler echocardiography, it is seen in two views. Jet length was greater than 2 centimeters in one view around mitral valve. Peak velocity for the flow was greater than 3 meters per second in one complete envelope in systole. Pansystolic jet was present. This meets the criteria for pathological MR. Next slide. And morphological feature, accessory mitral valve leaflet thickening was 3 centimeters. Restricted leaflet motions, caudal thickening, excessive leaflet tip motion during systole. This meets the definite echocardiographic criteria for rheumatic heart disease. So this is all about investigations.
Okay, so anybody has any queries on it? Or any clarification? Okay, you must be tired. Let's go to the treatment.
Yes, sir. So I'll present the treatment. So the aims of the treatment is to relieve the symptoms, prevention and control of disease-causing cardiac dysfunction and heart failure, retard the disease progression, and improve the quality and length of life.
Okay.
We'll advise general lifestyle measures to the patient. We'll educate the patient and relatives. We'll give treatment for the underlying cause of heart failure. We'll ask the patient to be on dietary modifications like restriction of salt and fluid, and we'll advise the patient to do moderate physical activity and exercise. The drug therapy, since there is decreased ejection fraction, the standard treatment would be beta blockers and ACE inhibitors. And since there is also fluid overload present, we'll prescribe diuretics like furosemide. And we can add on digoxin or ARBs or spironolactone. If there is no response to the drug treatment, then we'll consider implantable cardiac defibrillator if the ejection fraction is less than 35% or the NYHA class is less than equal to 3.
Oh, Shubhangi, did it very fast, short and sweet,
Yes,
without any salt. Now, I think you try to cover some congestive cardiac failure or left ventricular failure from ischemic heart disease or something. What is missing from here? Anybody?
So we'll
In
also
addition,
do the mitral valve repair.
if there is a need, yes. But what else is missing? Something important is missing based on this specific case. Anyone? I
So for
think
atrial fibrillation,
yes. What do you
uh,
do? Atrial fibrillation.
anticoagulants also will prescribe.
Not also, they are very important. They are very, not very important. They are very, very, very important. Every emergency, we would see a young person with a mitral valve disease who comes with stroke. 18 years, 20 years, whatever age you would say it, and they are just young, just got married, or just before that, or after that, and they come with full-fledged hemiplegia. It could be dense or otherwise dominant or non-dominant. Why did you get it? Because atrial fibrillation would lead to the clot,
Thrombosis.
which will embolize from the left atrial appendage into the left ventricle and into the brain straight up. It's 18 hours. Yes. So never
Yes.
forget the anticoagulation. Never forget the anticoagulation, because this emboli would go to brain, will go to kidney, will go to limbs. They can go anywhere. But stroke is what we see more commonly, and that is what very debilitating. Yes. So how do
Yes,
you give
sir.
anticoagulation to them?
So first we'll start on heparin, then we'll shift to warfarin because warfarin takes at least 5 days to show its effect.
So you give the heparin because warfarin in the beginning can cause side effects of skin necrosis,
Yes,
which
sir.
will be prevented if you start on. But anyway, what you need to do is you need to give warfarin, dicumaron, and warfarin has got a very narrow therapeutic window. So you have to titrate with PT, prothrombin time, and INR. To be done regularly. Once they are stable, nearly 2 times the INR is 2, then you put them on monthly PTINR, and then you can make it even less frequent. But what is important is warfarin, whenever they change a batch, they should do the test again, because each batch would have a different bioavailability. So it's a
Yes.
very finicky, funny drug. And of course, here we have a young man, but if it is a young woman, be careful that this drug can be teratogenic. And if they are thinking of become ladies thinking of getting pregnant, then one should consider switching back to heparin, particularly for the first trimester, because that is the time when teratogenic effects would come. So here, anticoagulation is very, very, very important. What is the other thing that is missing? One more thing. Antibiotics, somebody says, nobody says. Why do these persons need antibiotics? Tell me. He's a young man with mitral regurgitation, which you think is rheumatic in origin. Why would he need antibiotics on a regular basis or irregular basis?
So regurgitant lesions increases the risk of
Oh,
infective endocarditis.
yeah, not in, so there are, no. The antibiotics are not given to prevent infective endocarditis. The antibiotics are given to prevent rheumatic fever. And that is why when we were speaking of the history at the age of 14, we wanted to know whether he had more than one episode of this migratory polyarthritis. They can still get it, and so they are put on prophylactic every month penicillin, which is the long-acting benzathine penicillin, 1.2 mega units intramuscular, every 3 weeks to prevent any throat infection, streptococcal. so that they don't get more attacks of rheumatic fever and worsening or newer valve involvement. So one reason for giving antibiotics is to prevent the future attacks of
Recurrence of
rheumatic fever. Yeah, so that their problem is not complicated. It is not given to prevent infective endocarditis. So this is given on a regular basis, and at least up to the age of 45 years, one tends to give it.
yes, sir.
So that can be done, or you can decide younger age. These days, we don't see so much of rheumatic fever as we used to see earlier. But not to prevent infective endocarditis. The other reason you want to give it to prevent infective endocarditis would be if you are undertaking some intervention.
Yes, sir.
So which can lead to bacteremia. There, if you're doing some surgery or that is the time when you can give one odd course of antibiotics. So antibiotics can be given to prevent endocarditis when there is any intervention being considered, but it is not given on a regular basis to prevent endocarditis. But on a regular basis, you give to prevent rheumatic fever. Okay?
Yes,
Good.
sir.
So I'm finding that the responses are also going down and time also is going up. Any questions you want to ask here? Or clarifications or comments? Yes, anyone? No. So if there are none, I can only say that I can thank Sparsh and Sulakshana and Shubhangi and all the Century students. 100, I saw 100 sometime back. So all of you who participated in this panel discussion, and that too on an evening when it is so nice and rainy outside. Thank you so much. Have a nice evening,
Thank
and
you so much.
Eid Mubarak tomorrow. Celebrate, enjoy, stay safe, stay healthy. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.